All right, welcome back. It is Professor Brown Kishbal. We are going to be taking a look at an acute abdominal pain presentation. So, we are going to apply your foundational knowledge that you have obtained already in advanced pathophysiology, health assessment, and pharmacology. And we're going to take a look at it using diagnostic reasoning with the presentation of acute abdomen. You're going to identify, understand the diagnosis, the differential diagnosis, understand why the patients are going to present the way that they do, what the laboratory and diagnostic interpretation of the imaging entails, and then also understanding whether it's going to be surgical or a benign finding. So let's just take a look at a few main points when we are looking at abdominal pain. So even though we've had advances in clinical medicine, it's still actually a challenging complaint for both the PCP and specialty providers alike. It can be either a very benign or a very serious pathology, and anywhere on that spectrum. There needs to be a high degree of suspicion, providers' astute interpretation of what's going on. Goal is to identify and determine patients presenting with serious etiology, as many of them need a surgical intervention. There are certain patients who are going to present with an atypical feature, such as the elderly, patients that are pregnant, those with immunosuppression, and those taking opioids. Remember all those physiologic changes that happen with the elderly that lead to decreased immune response. They have lots of comorbid conditions that are going to allow for not only extra medications, but also interpretation of what's going on may be misconstrued because there's so many confounding variables present. Pregnancy, obviously, there's a lot of changes that go with a pregnant abdomen, change in uterus position, the compression of all organs, and poor pain localization due to the laxity of the abdominal wall. Immunosuppression, again, changes in immune ability to fight off inflammatory response as well as infection is going to pose problems and increase certain factors over others. And then opioids actually mask a lot of the abdominal pain signs and symptoms because that can make it challenging being able to diagnose patients who are already on opioids. A recurrent, unexplained abdominal pain in patients should always be high suspicion for sexual or physical abuse, and that is regardless of patient age or gender. Non surgical, which are going to be those more benign findings, actually account for up to 30% of patients requiring hospital admission. So, some important considerations in the acute abdominal pain workup are your initial thoughts. You must have a clear understanding of the anatomy, physiology of gastrointestinal pain. You need to perform an independent and thorough medical history and physical examination of each patient. I know this seems like you should not have to state this, but you should not rely on anybody else's documentation. You should perform that independently of what another provider tells you, as well as what may be written in the medical record already. Laboratory studies do give some value, but many are of limited value. There are often confounding disorders such as irritable bowel syndrome or functional abdominal pain syndrome or opiate induced bowel disease. These all may add to issues when you are trying to diagnose, and sometimes will just not allow for an accurate diagnosis, which does end up leading to unnecessary admission to the hospital and excessive testing. But again, high degree of suspicion, and also you're always going to err on the side that the more serious disease is presenting. So, what are those more serious diseases? Appendicitis, cholecystitis, obstruction, pancreatitis, mesenteric ischemia, bowel perf, diverticulitis. They actually account for two-thirds of hospital admissions when we're talking about acute abdominal pain. So, that's why you need a high degree of suspicion. Those are also associated with high morbidity and mortality. So, after obtaining comprehensive history, really eliciting a good pain interrogation is important. Pain in the acute abdominal presentation is going to give you lots of information. Pain is usually defined as more than 6 hours duration in a previously healthy person, and it requires a timely diagnosis and aggressive treatment. Always begin with the pain assessment. You need to understand presenting circumstances, temporal elements. Where is the pain location? What is its quality? Is there any radiation? What is the timing? Are there triggers, modifying, provocative, and palliative events? Is it somatic versus visceral? And is their pain out of proportion with physical findings? So let's take a look now and just put some of these factors into a grid like situation for you to understand. So these next two slides, go ahead and print them out because we're going to fill them in as we work through the acute abdominal presentation. All right, so let's take a look at concerns related to how the patient is going to present. If we look at pain timing, acute, sudden, and severe is very consistent with mesenteric ischemia, ruptured AAA, aortic dissection, ovarian torsion, uretolithiasis, and intra-abdominal hemorrhage. Insidious onset is more consistent with appendicitis and non-occlusive mesenteric ischemia. If you have paroxysmal intermittent pain, that is consistent with cholecystitis. It does likely progress to constant, but in the beginning, it is more paroxysmal and intermittent. Nocturnal pain is usually related to a duodenal peptic ulcer. Some palliative factors, if you eat food and it gets better, then that is usually related to a gastric ulcer. Provocative factors, making it worse. If you eat fatty foods, you're looking at cholecystitis. Any type of foods may be mesenteric infarction, gastric pepsid ulcer, duodenal ulcer. Movement, cough, or sneezing, that is going to be high suspicion for a peritonitis or peritoneal viscus or appendicitis. Characteristics of colicky and crampy pain are going to go with small bowel obstruction, large bowel, cholecystitis, or nephrolithiasis. Sharp pain is usually associated with ovarian torsion. Medications, NSAID, corticosteroids, and intrauterine devices. So, NSAIDs would be your peptic ulcer disease, corticosteroids as well, and also immunosuppression with the corticosteroids, and then IUD with ectopic pregnancy. Associated signs and symptoms. So, this is really high yield. If you're going to have nausea and vomiting with the presentation, then that may lead to small bowel obstruction, large bowel, or small bowel obstruction due to pylorus. Fever, we're going to have an infectious process such as appendicitis, cholecystitis, or diverticulitis. If diarrhea is present, then you may have diverticulitis or gastroenteritis. Constipation would be small bowel obstruction. The OBGYN concerns would be vaginal discharge, bleeding, and the GU dysuria, hematuria, black stool or melena. You're looking at those GI bleeds, anorexia, appendicitis, and cholecystitis. You want to look at your general appearance. So, are they malnourished, nourished? Is there jaundice, vital signs? Those are all going to give you some clues. Vital signs will also be important, whether they are hemodynamically unstable. Comorbid conditions. So, if there is atrial fibrillation, then we get concerned with potential mesenteric ischemia. Same with cardiovascular disease, as well as aortic aneurysm, and then referred cardiac ischemic pain. If you have a history of prior abdominal surgeries, then you're thinking adhesions, possibly small bowel obstruction, and then diabetes, think diabetic ketoacidosis, which presents with abdominal symptoms. Sickle cell, be that occlusive syndrome. Malignancy would lead towards small bowel obstruction. Social history includes tobacco, which may be mesenteric ischemia or AAA. Alcohol would go for pancreatitis or gallbladder disease, and then high risk sexual behaviors and PID. Recent travel would lead to parasitic infection. Your specific signs, we have another slide coming up on that, but just for purposes of kind of putting it all together, Murphy, psoas, Robsing's, obturator, and then rebound tenderness are the main ones. PE signs, so distension, is there an abdominal mass? Is there boroborami rebound? Is there abdominal fullness? Are you able to touch the abdomen? Is there lots of tenderness? When we take a look at location, you see the blue line here is into 4 basic segments. We have a couple in the middle here with epigastric, umbilical, and hypogastric. So starting from the top, referred pain means that you could have a cholecystitis or a perf duodenal ulcer. You might have right upper shoulder and clavicular pain. On the other side, perf duodenal ulcer and splenic rupture on the left. If we're talking about epigastric, think more cardiovascular, AAA, angina MI, as well as peptic ulcer disease, pancreatitis, or esophagitis. Right upper quadrant, cholecystitis, pneumonia pleurisy, or pyelonephritis. You can see that they are highlighted either yellow or blue. The yellow ones are going to be your visceral pain, and the blue ones are going to be your somatic pain. So, right lower quadrant, we have cholecystitis, late appendicitis, OBGYN complaints, pyelonephritis, and hernia. If we do umbilical and hypogastric, we're really looking at mesenteric ischemia, early appendicitis, small bowel, or triple A. Left lower quadrant, irritable bowel syndrome, OBGYN complaints, pyelonephritis, diverticulitis, and hernia. Left upper quadrant is going to be peptic ulcer disease, splenic infarct, pancreatitis, pneumonia, and pyelonephritis. When we take a look at those exam and labs, so examination of the abdomen and proper history taking is really important as it will yield a correct diagnosis at least 50% of the time. Please refer back to your advanced health assessment for the specifics on how to perform a proper abdominal assessment. The context of this video is not going to go into that. Laboratory studies. Overinterpretation versus underinterpretation is always a potential situation. Understanding normal will not exclude some diagnoses is very important. And an example of this would be that a normal urinalysis does not exclude nephrolithiasis. Just because you don't have blood does not mean that you don't have a kidney stone. And a normal ECG or chest x ray does not exclude pulmonary or cardiac disease as a potential etiology. Often, patients are actually much sicker than their lab findings suggest, especially in those atypical patients. Here is a synopsis of those signs so that you can understand how to perform them and what does it indicate. Imaging that we're going to use in the acute abdominal pain, and this is that initial testing. So we often do plain films. They are often performed, but they really don't help us in much of the management. They may reveal radioepic gallstones, renal, or pancreatic stones, and they may give us free air presence and diaphragm rupture evidence, which would be one of the more severe presentations. So often we do start with a plain film, but other than those signs and symptoms, it's not going to really help us. Ultrasound is a big one, readily available, transportable, and does not have any ionizing radiation. But it's relatively insensitive to patients with obesity and adiposity, intrinsic bowel, or retroperitoneal disease presentations. The preferred agent and benchmark imaging modality for the evaluation of acute abdominal pain is the multi-detector computer tomography, so your CT scan. MRI is also used, and it is ideal for assessing bowel wall inflammation and also does not have any ionizing radiation. However, it's difficult to interpret at times, very cumbersome, and is very expensive. When we're talking about the differential diagnosis, it is all based on history, physical examination, and the appropriate laboratory and radiological procedures. For example, if you have right upper quadrant pain, cholecystitis, pneumonia, pyelonephritis would be your top differentials. And then based on symptoms, that is going to help you determine what workup you need to rule in, rule out. All right, let's take a look at labs for the gastrointestinal system that are going to be used in our acute abdominal workup. So we would get a urinalysis, obviously, to rule out any issues with an infection, urinary tract infection, or possible pyelonephritis, and also may identify kidney stone. Next up is the serum or urine HCG that would be pertinent for those who have the ability to become pregnant. CBC with DIP, so you're looking for a leukocytosis, which is often present, especially if we have an inflammatory infectious such as appendicitis, cholecystitis, PID, PUD, acute mesenteric ischemia, intussusception, hepatic abscess, likely going to show up for many of our problems. Electrolyte panel is going to give you evidence of hypochloremia and hypokalemia, which would be present in the later stages of intestinal obstruction. The glucose would obviously be elevated if there was a DKA issue. Also, if pancreatitis, if the insulin secretion is compromised. And then BUN may be elevated with AAA if the renal arteries are compromised. LFTs would be looking for your aminotransferases, bilirubin and alk phos to give you more of a liver profile. And then your lipase and amylase. So these need to be significantly elevated, greater than 3 times the upper limit normal. Serum lipase is actually preferred to amylase, and they do have similar sensitivity and specificity, but lipase levels remain elevated for a longer period of time, up to 14 days versus 5 days for amylase. Lactic acid elevated in acute mesenteric ischemia. The exact level depends on the severity of that ischemia. Inflammatory markers, this is going to be your C reactive, and that is that non-specific inflammation marker. And then coag studies. So this would be for patients with suspected vascular causes, such as your aortic dissection, ruptured AAA, or acute mesenteric ischemia. FIT testing is used for patients that are high risk colorectal cancer. So that would be unexplained weight loss, abdominal pain, age 40 or above. The FIT test is the quantitative fecal immunochemical test, and that is one of the ways that we evidence of the cancer. If you're concerned with any type of breathing issue, vital signs and pulse ox are indicated. When we talk about the differential diagnosis, pretty much everything that we talked about in this lecture is a differential for abdominal pain. So what you need to know is, based on location, features of the pain, clinical presentation, and history taken, your differential diagnosis can be lumped into broader categories such as an obstructive issue, an inflammatory issue, a perf issue, gynecologic, metabolic, or some non-specifics. So wrapping up the acute abdominal pain, attached to your gastrointestinal lecture, your main slides, are all of the acute abdominal pain pathophysiologic disturbances. Please refer back to those for the specifics of the disease processes that we talked about in this overview topic. Remember, a high degree of suspicion is needed. You need a good history and physical exam. Labs may help you. Gold standard is imaging. And remember that 2/3 are surgical interventions, which require a timely, astute diagnostic reasoning process to improve risks. ER if unstable. All right, thanks so much for listening. I will see you and talk to you guys on our next video. Take care.